Surgical Counts, an evidence-based quality improvement project by Downie. What is the surgical count? The surgical count is to verify the number of items being used in a procedure, to identify any packaging errors, and to monitor the number of items being used during the operation or procedure. It's a process involving two people, one who must be a registered nurse, whereby they look at the countable items together. One person manually separates each item and they audibly count and visualize the number of items together. Surgical counts must be performed in procedures where an incision is made or a wound is created and surgical items are used. So what's a retained surgical item? A retained surgical item is an unintended retention of a surgical object or instrument in a patient after surgery or other procedures and is considered a never event. These never events are medical errors that have significant adverse and serious complications resulting in significant disability or death. These incidents are considered unacceptable and imminently preventable. The Surgical Count Project. Prior to initiation of the Change Project, review of the event reporting system identified two cases of retained surgical items, one involving a sponge and the second involving a lap, within the last year, and an average of 5 miscounts per month. A miscount is a count discrepancy that occurs at an interim count and is reconciled prior to the end of surgery. As a result of these events, our department, administration, and chief of surgery have come together and initiated a quality improvement project to improve and standardize our count process and to educate staff. The aim of the Change Project would be to reduce the count discrepancies or miscounts by 50% within the next 2 months. Our quality improvement project will include the initiation of an accounting bag system, elimination of paper count sheets for soft goods, and initiation of a white dry erase board for counting of soft goods. The goals and outcomes of the project include to standardize the surgical count process to prevent errors, decrease the incidence of count discrepancies, and prevent a retained surgical foreign object. Current literature. Goldman and Feldman reported the following. The National Quality Forum includes retained surgical items on the list of surgical reportable events. Centers for Medicare and Medicaid refer to RSIs as a never event. A key element in the successful implementation and practices and prevention of RSIs is having consistent multidisciplinary approach during all surgical procedures. All perioperative team members share in the responsibility for preventing RSIs. All surgical counts should be done with minimal distraction and unnecessary activity. All counts should be performed using a standardized procedure. This reduces the risk of RSIs and allows for continuity and efficiency within the perioperative team. Steelman, Grayling, and Perkonkova reported the following. Retained surgical items are estimated to occur in 1 in 5,550 surgeries. RSIs is the most frequent sentinel event in 2011 with 188 events reported to the Joint Commission. Nurses rated preventing RSIs as one of the top 5 priorities for perioperative patient safety. Freitas, Silvera, Clark, and Galvo reported the following. RSIs cause physical, emotional, and financial consequence for patients in healthcare facilities. The need to return to surgery in some patients result in death, damages, malpractice liability costs, and legal fees. Standardized counting process and improved communication and multidisciplinary teamwork is essential in preventing RSIs. Nurses have a key role in implementing this practice to ensure safety of the surgical patient. Risk factors of RSI includes count errors, unexpected intraoperative events, extended surgery time, complexity of the surgical case, high body mass index, emergency and urgent surgery, and increased number of staff members involved in a surgical procedure. Implementation of the new surgical count policy. The plan and the steps needed to initiate our change include formation of the Surgical Count Committee, including dedicated registered nurses, surgical technologists, nurse leaders, nurse educator, and a surgeon. The group was instrumental in facilitating and implementing this project. The unit supervisors and nurse educator were responsible for training the staff. Education include web-based training on our talent management education site and demonstration during staff meetings on how to properly utilize the sponge accounting system. The steps to take should a miscount or incorrect account occur, And registered nurse and surgical technologists were also required to undergo a competency evaluation by the nurse educator or supervisor by demonstrating and verbalizing the appropriate counting process. Procedural changes include counts to be performed uninterrupted, for counts to be initiated during specified times during the case, and new policy and procedure for incorrect or miscounts. Materials to be utilized. The hanging blueback plastic sponge holders will be reviewed on the next slide. The plan included implementation of a white dry erase board. When the project was implemented, the dry erase boards for the operating room had not been ordered. We did implement other visual aids. These will also be reviewed on the next slide. These posters were hung in the operating room as a reminder to account for all the sponges and laps during a case. Because the dry erase boards were not implemented, we continued to utilize the count sheets for soft goods. We had several different count sheets available prior to the count change project that different specialties utilized. The count committee standardized the form to reduce confusion and the potential for errors. This one standardized form is to be used in all cases until the dry erase boards can be implemented. Audits of the counts were performed by the unit supervisors and assessed the following components of the surgical count. Did 2 staff members, one of whom must be a registered nurse, perform all the surgical counts per policy? Were all the counts carried out at the appropriate times? Did the staff members performing the count verbalize that the count was correct to the surgical team? If the count was incorrect, did the surgical team follow the count policy? Was the team interrupted during the surgical count? What do I expect to happen when the steps are implemented? The measurable outcomes and expectations include increased communication between the surgical team, reduction in the amount of miscounts that have occurred, strict adherence to the surgical count policy, no incidence of a retained surgical item, and minimize interruptions and distractions during the surgical count. The sponge accounting system displayed on the bottom right is used so the entire surgical team can visualize all the sponges and laps. These items come in packs of 5 and 10 and are counted concurrently in groups of the original unit. They must be separated, open, and rolled, then placed in separate pockets in the system, filling it from bottom to top. Items are placed throughout the case, and all used and unused items must be placed in these systems at the end of the case and visualized by all team members, that there are no empty pockets prior to the patient leaving the operating room. To also assist staff, we have 2 visual aids that are demonstrated on the slide that are displayed in the operating room. These remind staff to check for sponges, to pause while the surgeon does a methodical wound exam, and to show all the team members that sponges and laps have been accounted for. Conclusion: 50 audits of the new surgical count procedure were performed. During the 2-month implementation period, our department did not have a retained surgical item, event, or an incorrect surgical count. We experienced 2 cases of miscount during this period. The miscounts did not involve the sponge or lap. Both incidents involved a needle miscount. The needles were found and the count reconciled prior to completion of the case. Both surgical teams followed the new policy correctly. Audits indicated 98% compliance using the sponge accounting system, 100% compliance verbalizing counts and results to the surgical team. Staff reported improved communication and satisfaction with having the ability to visualize sponges and laps, and 50% reduction in the interruptions and distractions during the count. Evaluation and improvements. My aim was obtained and we had over 50% reduction in the amount of count discrepancies during the 2-month implementation period. 18 out of 20 registered nurses and 20 out of 20 surgical technologists reported satisfaction with the sponge accounting system. The 2 nurses who reported dissatisfaction stated that the IV poles the sponge accounting system was set up on were inadequate and the holders have fallen off, making use difficult. Since this report, we have replaced the IV poles and no further complaints were made about the system. The second phase will need to be initiated once the whiteboards have been ordered and obtained. The Surgical Count Committee is working on planning what will be documented on the board and where to display the board in the OR so all the team members can adequately visualize it. We did note in our audit that the teams were frequently interrupted and distraction during the surgical count, and we need to decrease these distractions and interruptions to prevent errors, miscounts, and a retained surgical item.